Greetings, enthusiasts of the medical world, and a very warm welcome back to ERMP and Beyond, your premier destination for delving into the heartbeat of clinical medicine. As always, we're set to navigate the practical aspects of medical science, dissecting intricate cases that both challenge our intellect and expand our knowledge. In this platform, we confront the real-world scenarios of healthcare. Together, we'll deconstruct complex diagnoses and sharpen our clinical acumen. Anticipate engaging in dynamic, evidence-based dialogues, enriched by the priceless perspectives that stem from actual medical practice. So, without any delay, let's dive into the depths of today's medical enigma. A 17-year-old adolescent was found unconscious in his room. Physical examination revealed drooling of saliva with coarse crepitation and pinpoint pupil. After physical examination, the ER physician suspected poisoning. What is the most likely substance for the poisoning? A. Hypochlorite. B. Organophosphate. C. Cocaine. D. Paracetamol. You have 15 seconds to consider your options. Let's delve into the fascinating world of biochemistry and toxicology, focusing on the impact of the aforementioned agents on our body. First, let's talk about the chlorine and hypochlorites. Okay, imagine chlorine as a green-yellow gas that's not too shy to mix with water, yet it carries an aroma that's unmistakably sharp. Yes, that's chlorine for you. When it meets water, it transforms, creating hydrochloric acid and hypochlorous acid, both of which are quite the characters, with one being a caustic and the other creator of free radicals. When we think of chlorine, we often think of its use in household cleaners and as a sanitizer for pools. But there's more to it than just cleaning power. For instance, sodium hypochlorite, which is a type of chlorine compound, is found in many bleaches and purifiers. The concentration of this chemical in household bleaches usually ranges from 3 to 10%, and depending on the product, the pH level can vary from mildly irritating to downright corrosive. When it comes to pools, the chlorine story gets even more interesting. Pool treatments often use different forms of hypochlorites, like lithium, calcium, or sodium, and these can be quite concentrated, up to 70 or 80%. The pH levels here can also vary widely. Now, for those who take care of swimming pools, handling chlorine tablets carelessly can lead to exposure to chlorine gas, which is definitely something to avoid. Commercial pool services often use a liquid form of chlorine gas for chlorination, which is another way people might come into contact with this gas. But what about when you're cleaning at home? Mixing different cleaning agents, especially acids with bases, can accidentally produce chlorine gas. This is something firefighters might encounter too, when they're dealing with fires that burn materials containing chlorine, like certain plastics. Understanding the pathophysiology of hypochlorite poisoning is vital for prevention, prompt diagnosis, and effective treatment. So let's begin by understanding what happens when hypochlorite, a strong oxidizing agent, encounters organic tissue. Our exposure to these chemicals can happen in several ways. Direct contact with the skin, ingestion, or even inhalation of the fumes are all possible routes. Hypochlorites are known to be irritants, and the resulting damage can be quite severe. Corrosive injuries can affect sensitive areas like the eyes, the skin, and the respiratory and gastrointestinal systems. The type of tissue pathology we often see is a liquefaction-type necrosis. This is not just a surface issue, it's a deep-seated tissue injury where fats and proteins undergo saponification, leading to profound tissue damage. But the danger doesn't stop there. When hypochlorite solutions mingle with tissues, they inflict local damage and, alarmingly, can produce chloramine gas if they come into contact with ammonia. This gas is notorious for causing choking and severe respiratory distress. Now, let's turn our attention to the specific pathophysiological effects on the airways following chlorine inhalation. This gas, when it meets the moisture in the trachea and bronchi, transforms into hydrochloric and hypochlorous acids. These aren't just any acids, they're reactive, and they start to interact with the airway linings. What happens next is a bit like a chemical domino effect. Reactive oxygen species, which include molecules like superoxide and hydrogen peroxide, begin to form. These molecules can be quite damaging, and they come from two places: the neutrophils rushing to the scene, and a kind of power failure in the mitochondria, the cell's energy factories. But wait, there's more. Neutrophils have another trick up their sleeve. They can turn hydrogen peroxide into even more of that reactive hypochlorous acid. And to add to the mix, our body's own enzymes can produce nitric oxide, which then combines to form peroxynitrite. Together, these chemicals create a storm of reactions leading to swelling, inflammation, and the airways tightening up immediately, with effects that can last up to 6 to 12 hours. We're going to look into the clinical features of chlorine gas exposure, which can significantly impact both the upper and lower respiratory tracts. As we've mentioned just a few minutes before, when chlorine gas is inhaled, it reacts to form hydrochloric and hypochlorous acid in the lower respiratory tract, leading to a potentially slow-developing caustic injury. In cases of acute exposure, individuals may experience irritation or injury to the mucous membranes and lung parenchyma. This can lead to serious conditions such as airway compromise, pulmonary edema, and acute respiratory distress syndrome, which might not manifest until up to 6 hours post-exposure. Repeated low-intensity exposure to chlorine gas can result in chronic respiratory issues and symptoms similar to the flu. Over time, this may lead to reactive airways dysfunction syndrome and reactive upper airway dysfunction syndrome. Contact with dermal hypochlorite can cause allergic reactions or irritant contact dermatitis, while exposure to liquid or aerosolized hypochlorite can lead to irritant conjunctivitis and chemosis. On the other hand, ingestion of industrial-strength hypochlorite solutions can cause severe damage to the esophagus and stomach, potentially leading to perforation, although such severe outcomes are rare with the accidental ingestion of household bleach, which is typically around 5% concentration. Lastly, acute inhalation of chloramine gas can cause rapid irritation to the nasopharynx, and in high concentrations or enclosed spaces, it can lead to pulmonary edema and ARDS. Chronic exposure to low levels of chloramine gas is associated with occupational asthma. It's crucial to understand these risks to ensure proper safety measures and immediate medical attention in case of exposure. Let's keep this in mind as we continue our discussion on the management soon. Let's explore the steps in managing exposure to caustic substances and irritants. When it comes to dermal burns, the first and foremost action is decontamination. It's crucial to thoroughly wash the affected area with copious amounts of soap and water to prevent further damage. Now, if the eyes are exposed, immediate attention is required. The eyes should be flushed with sterile water or normal saline. For pain relief and to facilitate the flushing process, applying an ophthalmic anesthetic may prove to be advantageous. After decontamination, we must assess the depth of skin burns and check for corneal burns or open globe injuries in the eyes. For extensive burns, fluid resuscitation is crucial, akin to the treatment for thermal burns. Moving on to the respiratory tract, we need to be vigilant for signs of edema or injury. Symptoms such as stridor or hoarseness can indicate upper respiratory tract issues, which should be confirmed through a visual inspection of the airway. If lower respiratory tract injury is suspected, a chest radiograph is necessary. Be on the lookout for clinical signs like fast breathing, low oxygen levels, retractions, muted breath sounds, wheezing, crackles, and respiratory distress or impending failure. Chemicals, like chlorine or nitrogen oxides, may cause lung injuries that appear later, necessitating extended observation up to 6 or 12 hours. For treatment, provide supportive care for both upper and lower respiratory tract injuries. In cases of stridor, nebulized racemicepinephrine can be administered, and early tracheal intubation should be considered to prevent worsening of airway injury or edema. Bronchospasm can be treated with inhaled bronchodilators, such as albuterol. In severe cases involving acute lung injury or ARDS, mechanical ventilation may be required. It's important to note that symptomatic patients need to undergo endoscopy within 12 to 24 hours post-exposure for assessment, and depending on the severity, may require antibiotics or surgery. Let's proceed by examining whether this particular boy has been exposed to organophosphates and discuss the implications of such an exposure. Organophosphate poisoning is a severe condition affecting the nervous system. It occurs when acetylcholinesterase, an enzyme crucial for breaking down acetylcholine, is inhibited. This inhibition causes an excess of acetylcholine, leading to the overstimulation of nerve fibers at both nicotinic and muscarinic receptors. Organophosphates, the culprits behind this poisoning, are found in everyday substances like pesticides, insecticides, and herbicides. They're also known for their more nefarious use as nerve agents in chemical warfare. Typically, those working in agriculture are most at risk, as they're in frequent contact with these chemicals. Exposure can happen through ingestion, inhalation, or even direct contact with the skin. Imagine a molecule, an organophosphorus agent, that when introduced into the body, binds to the enzyme acetylcholinesterase. This binding triggers a transformation within the complex, a process we refer to as aging. This aging makes the enzyme permanently resistant to the antidote pralidoxime, meaning once this change occurs, there's no turning back. Now, let's talk about the effects of this toxicity. The natural history of this toxin within the body varies. It depends on its chemical makeup, how quickly it inhibits acetylcholinesterase, and how it enters the body. Whether it's through ingestion, inhalation, or skin contact, each route affects the timeline of symptoms. Typically, if ingested or inhaled, symptoms can appear within 3 hours. However, if the exposure is through the skin, it might take up to 12 hours for any signs to show. Acute toxicity from organophosphorus agents presents with manifestations of cholinergic excess. The excess of cholinergic activity leads to a range of symptoms, primarily affecting the autonomic nervous system, the neuromuscular junction, and the central nervous system. The parasympathetic nervous system, which relies heavily on acetylcholine, is particularly vulnerable. This system is regulated by two types of receptors, the nicotinic cholinergic receptors at the autonomic ganglia and the muscarinic cholinergic receptor subtypes at the end organs. When we observe the clinical presentation of acute cholinergic toxicity, several key features stand out. Patients may exhibit bradycardia and meiosis. Additionally, there's an increase in lacrimation and salivation, along with bronchuria, which is an excessive discharge of mucus from the lungs, and bronchospasm. Other symptoms can include frequent urination, vomiting, and diarrhea. Interestingly, patients also experience diaphoresis, or excessive sweating, due to the activation of sweat glands through the sympathetic nervous system, which, in this case, stimulates postganglionic muscarinic receptors. However, in some instances, the symptoms may present differently, with mydriasis and tachycardia. This occurs because the sympathetic ganglia, which are part of the nervous system that typically responds to stress, also contain nicotinic receptors. For the exam purpose, it's crucial to have strategies in place to recall the plethora of signs and symptoms that may be presented. A useful method to enhance our memory is through the application of mnemonics. Let's focus on the muscarinic signs of the acute cholinergic crisis, which can be effectively remembered by employing one of two well-established mnemonics. The first mnemonic is DUMBLES, encapsulating defecation, urination, meiosis, bronchuria, bronchospasm, bradycardia, emesis, lacrimation, and salivation. The second mnemonic is the sludge BBB, which stands for salivation, lacrimation, urination, defecation, gastric emesis, bronchuria, bronchospasm, and bradycardia. It's imperative to acknowledge, however, that these mnemonics do not encompass the critical central nervous system and nicotinic effects of toxins. The nicotinic effects are characterized by fasciculations, muscle weakness, and paralysis, which occur due to the stimulation of acetylcholine receptors at the neuromuscular junction. This process is similar to the depolarizing impact of succinylcholine, which results in neuromuscular blockade. Furthermore, both nicotinic and muscarinic receptors have been discovered within the brain, implicating their role in central respiratory depression, lethargy, seizures, and even coma. It's essential to consider the full scope of effects that these toxins can induce, beyond what our mnemonics can summarize. We'll delve into a condition known as the intermediate syndrome, also known as the neurologic syndrome. This is a significant concern, as between 10 to 40% of individuals exposed to organophosphorus poisoning experience this distinct neurological disorder. It typically emerges 1 to 4 days following the initial exposure, after the acute cholinergic symptoms have subsided. The syndrome is characterized by several neurological symptoms. Patients may exhibit weakness in neck flexion, a reduction in deep tendon reflexes, abnormalities in cranial nerves, proximal muscles weakness, and even respiratory difficulties. Now, what predisposes someone to this intermediate syndrome? It seems that exposure to an organophosphorus agent with high fat solubility is a key risk factor. Additionally, receiving insufficient doses of oximes, which are antidotes for organophosphate poisoning, may also contribute to the development of this condition. Interestingly, this syndrome is a rare occurrence in cases of carbamate poisoning. The good thing is that with the right supportive care, which may include extended mechanical ventilation, the majority of patients recover completely from neurological impairments in about 2 to 3 weeks. It's fascinating to note that the progression and recovery of the syndrome correlate with the levels of acetylcholinesterase in red blood cells. Moreover, nerve conduction studies have shown unique postsynaptic abnormalities in patients with intermediate syndrome, setting it apart from other forms of delayed neurotoxicity. This distinction is crucial for healthcare professionals when diagnosing and treating the condition. Lastly, on the clinical pictures of organophosphate poisoning, let's consider the complexities of delayed and long-term neuropathology. This condition unfolds over a span ranging from weeks to years. A notable example is the neuropathy induced by certain organophosphorus agents, such as chlorpyrifos, which manifests 1 to 3 weeks post-exposure. Interestingly, carbamates are seldom linked to this condition. The underlying mechanism is thought to be the inhibition of an enzyme known as neuropathy target esterase, which plays a crucial role in cellular metabolism of esters, rather than any impact on red blood cell acetylcholinesterase activity. Patients affected by this condition initially experience transient, painful sensations resembling a stocking glove pattern, which is soon followed by a symmetrical motor polyneuropathy. This presents as a flaccid weakness starting in the lower limbs and progressively involving the upper limbs. Typically, sensory impairments are minimal. The neurotoxicity primarily targets the distal muscle groups, although severe cases can also impact proximal muscle groups. Diagnostic tests, such as electromyograms and nerve conduction studies, indicate a reduced activity in motor conduction units. Moreover, histopathological examination of peripheral nerves shows a characteristic degeneration of large distal axons, known as Wallerian degeneration. It's important to note that the risk of developing this delayed neuropathy does not correlate with the severity of the initial acute cholinergic toxicity. Some agents, like parathion, despite being potent cholinergic substances, do not trigger this delayed condition. Conversely, compounds like triorthochiral phosphate, which show minimal cholinergic symptoms, are often implicated in such neuropathies. The prognosis varies. While most mild cases see improvement over time, severe instances can lead to an upper motor neuron syndrome, marked by spasticity in the lower limbs, resulting in permanent disability. As we explore these nuances, it becomes clear that the pathophysiology of organophosphorus-induced neuropathy is as intricate as it is critical to understand for effective medical intervention. When we face with an organophosphate poisoning case, time is of the essence. Our immediate goal is to stabilize the patient, halt further absorption of the poison, and begin administering life-saving antidotes. It's crucial that every patient showing symptoms receives a combination of oxygen therapy, atropine, pralidoxime, and a benzodiazepine. These are not just medications, they are the frontline defenders in battling this poisoning. Atropine serves to block the receptors that have been overstimulated by the poison, while pralidoxime works to reactivate the enzyme acetylcholinesterase. Managing these patients can be a complex task that requires persistence and precision. If the poison has been absorbed through the skin, we must act swiftly to decontaminate the area. This involves the thorough removal of the patient's clothing and rigorous cleansing of the skin to prevent further absorption. For those patients who are severely affected, with a significantly altered mental state or on the brink of respiratory failure, We must provide 100% oxygen and prepare for immediate tracheal intubation. It's important to note that succinylcholine is contraindicated for rapid sequence intubation in these cases due to its potential to worsen the poisoning. Often, patients will present with bradycardia and hypotension, especially in moderate to severe cases of poisoning. To address this, we must ensure adequate volume resuscitation using isotonic crystalloid, alongside other resuscitative measures and diagnostic procedures. Ladies and gentlemen, let's delve into the first line of defense for organophosphate poisoning, atropine therapy. This is a crucial intervention recommended for patients exhibiting any signs of cholinergic toxicity resulting from organophosphate poisoning. The initial dosage is quite specific. We administer 2 to 5 mg intravenously for adults and 0.05 mg per kilogram for children. It's imperative to monitor the patient closely because if there's no noticeable effect, we proceed to double the dose every 3 to 5 minutes. This is continued until we see a significant reduction in the pulmonary muscarinic symptoms. Moving on to oxime therapy, which involves agents such as pralidoxime. This is another cornerstone treatment for patients showing clear signs of cholinergic toxicity. It's also essential for those with neuromuscular dysfunction or those who have been exposed to organophosphorus agents that are known culprits of delayed neurotoxicity. The World Health Organization has set forth guidelines for the administration of pralidoxime, an intravenous bolus therapy with a minimum of 30 mg per kilogram for adults and a range of 25 to 50 mg per kilogram for children, tailored according to the severity of the symptoms. A critical point to remember is the rate at which pralidoxime is administered. It must be done slowly, over a span of 30 minutes, and pralidoxime should never be administered without concurrent atropine therapy. Lastly, we address the treatment of seizures induced by organophosphate poisoning. Benzodiazepines are the final component of our treatment protocol. These seizures are best managed with a benzodiazepine, and in a prophylactic capacity, diazepam can be particularly effective. For instance, a 10 mg intravenous dose of diazepam can significantly mitigate neurocognitive dysfunction following poisoning by an organophosphate agent. As we delve further into our exploration of acute cocaine poisoning, it's crucial to understand the substance at the heart of this matter. Cocaine is often hailed as the most powerful natural stimulant known to us. This potent substance is derived from the leaves of the coca plant, known scientifically as Erythroxylum coca, a plant native to the Andean highlands of South America. The indigenous people of this region have long utilized coca leaves, either by chewing them or brewing them into a tea. This practice serves as a means of refreshment and a way to alleviate fatigue. It's a tradition that mirrors the customs found in other cultures, such as chewing tobacco or consuming tea and coffee. These practices, while culturally significant, also bring to light the varied uses of naturally occurring stimulants across different societies and how they have been integrated into daily life. However, when we speak of cocaine in the context of acute poisoning, we are referring to a far more concentrated and potentially harmful form of this natural product. It's this aspect that we'll be examining closely, understanding its impact on health and well-being. Let's see the pathophysiology of cocaine and its multifaceted impact on the body. Cocaine, a potent stimulant, exerts its effects through several mechanisms. Firstly, it acts as an indirect sympathomimetic agent, enhancing the availability of biogenic amines, such as serotonin, dopamine, norepinephrine, and epinephrine, by inhibiting their reuptake at the synapse. This blockade results in heightened stimulation of various adrenergic receptors, which can lead to increased heart rate and blood pressure due to vasoconstriction. The sensation of euphoria that often accompanies cocaine use is primarily due to the inhibition of serotonin reuptake in the central nervous system. However, the addictive nature of cocaine is closely tied to its impact on dopamine reuptake, particularly within the neural pathways that connect the limbic system to the frontal cortex, a connection that has been extensively studied in animal models. Another key mechanism by which cocaine affects the body is through the blockade of sodium channels. By altering the dynamics of neuronal sodium channels, cocaine can slow nerve conduction, mirroring the effects of local anesthetics. This action not only contributes to its local anesthetic properties but also affects cardiac function by slowing the sodium current in cardiac myocytes. In cases of severe overdose, This can lead to a noticeable prolongation of the QRS complex on an electrocardiogram and a decrease in the heart's pumping ability. Lastly, the third mechanism is excitatory amino acid stimulation. When cocaine is introduced into the system, it significantly elevates the levels of certain amino acids, namely glutamate and aspartate, within the brain. This increase is particularly notable in the nucleus accumbens, a region often associated with the brain's reward circuit. Glutamate, the primary excitatory neurotransmitter in the central nervous system, plays a pivotal role in this process. It facilitates the transmission of electrical signals between neurons, essentially exciting them to action. Aspartate, while functioning in a similar capacity, is a bit more enigmatic. Its precise function as a neurotransmitter isn't as clearly understood, but we do know it's selective, influencing only specific subtypes of glutamate receptors. Moreover, aspartate is not just a neurotransmitter, it also acts as a building block for the production of glutamate. This intricate interplay between cocaine and these excitatory amino acids sheds light on the complex biochemical pathways that underlie addiction and the reinforcing properties of this substance. Understanding this mechanism is crucial as it informs potential therapeutic targets for treating cocaine dependence. By exploring these pathways, we can begin to unravel the web of interactions that lead to the addictive behaviors associated with cocaine use. We're going to delve into the clinical manifestations associated with cocaine use. Cocaine has a dose-dependent impact on the human body, elevating heart rate and blood pressure. This is often accompanied by heightened alertness, sharpened focus, and a profound sense of euphoria and well-being. However, these initial sensations are typically followed by an intense craving for more of the substance. It's important to understand that cocaine can induce toxicity across various organ systems, primarily due to its hemodynamic effects. Starting with the cardiovascular system, acute cocaine use leads to arterial vasoconstriction and promotes thrombus formation. This results in a rapid heartbeat, elevated blood pressure, and an increased demand for oxygen by the heart muscles, along with heightened vascular shearing forces. Cocaine-induced coronary vasoconstriction occurs in a dose-dependent manner and is linked to cardiac ischemia in a small percentage of patients presenting with cocaine-related emergencies. In scenarios of high cocaine concentration in the bloodstream, the substance's negative inotropic effects may precipitate a sudden decline in the left ventricular function, potentially leading to heart failure. Additionally, cocaine can trigger both supraventricular and ventricular dysrhythmias, either through its direct action on myocardial receptors or as a secondary effect of myocardial ischemia. While rare, aortic dissection and rupture have been documented following cocaine use. With chronic use, cocaine can expedite atherogenesis and cause left ventricular hypertrophy. These conditions significantly elevate the risk of myocardial ischemia or infarction and may culminate in dilated cardiomyopathy. On the central nervous system, this powerful stimulant can lead to a range of complications, from the restlessness of psychomotor agitation to life-threatening seizures and coma. One of the most severe reactions is hyperthermia, which occurs when the body's natural cooling mechanisms are overwhelmed by heat generated from constant movement, coupled with cocaine's effect of narrowing blood vessels, preventing heat escape. In some cases, this can be fatal, with mortality rates reaching up to a third of those affected. But what triggers this psychomotor agitation? Cocaine increases levels of certain amino acids in the brain that excite neural activity, along with a surge in neurotransmitters like norepinephrine, serotonin, and dopamine. This heightened activity can lead to the dangerous rise in body temperature we mentioned earlier, especially in warm environments. Seizures are another serious risk, presenting in about 3 to 4% of emergency department visits linked to cocaine use. These seizures can happen after taking large amounts or even in those who've used cocaine habitually, without any previous history of seizures. Moreover, cocaine use can lead to both temporary and permanent neurological deficits, including strokes and bleeding within the brain. Reports have documented various types of hemorrhages associated with cocaine use, and though less common, some individuals may experience paralysis due to reduced blood flow to the spinal cord. Headaches are a common side effect. These aren't your typical headaches, they're often the result of neurotransmitter dysregulation or changes in blood flow within the brain. For those who use cocaine intravenously, they might experience occipital or bilateral headaches that start right after use and can last for up to 2 days. On the other hand, Individuals who use cocaine intranasally often report throbbing frontal headaches. Interestingly, smoking crack cocaine can lead to either type of headache. It's also worth noting that these headaches frequently come with unpleasant companions, like nausea and vomiting. But the effects of cocaine don't stop at physical discomfort. The drug can also induce psychotic symptoms that are quite severe. These may include paranoia, delusions, or hallucinations. In fact, these symptoms can be so intense that they mimic the positive symptoms of schizophrenia. It's a stark reminder of the powerful and often detrimental influence cocaine has on both the mind and body. Cocaine also has harmful effects on the respiratory system. When crack cocaine is smoked, it requires high temperatures to vaporize. This process can lead to angioedema and pharyngeal burns. The injuries we see in the upper and lower airways are primarily due to the inhalation of heated fumes, not a direct toxic effect of the drug itself. Alveolar hemorrhage is a serious condition that can result from this. Now, when cocaine is used intranasally or through inhalation, it's associated with some severe complications like pneumothorax, pneumomediastinum, and pneumopericardium. These are often a result of the Valsalva maneuver, which users apply to prevent exhaling the drug, trapping it in the lungs. Cocaine can also exacerbate reversible airway diseases and cause bronchospasm, leading to what's known as crack lung, which is characterized by shortness of breath. Moreover, cocaine use leads to vasoconstriction, vasospasm, and increased thrombus formation, predisposing users to pulmonary infarction. Those affected typically experience shortness of breath and pleuritic chest pain, symptoms that can be mistaken for pulmonary embolism. However, it's still unclear if cocaine users have a higher risk of pulmonary embolism. Moving on to the gastrointestinal and renal effects, cocaine users often suffer from perforated ulcers at a disproportionate rate. The reasons could be an increased sympathetic tone that boosts gastric acid production or local ischemia in the gastrointestinal tract. Cocaine is also linked to ischemic colitis, intestinal infarction, and metabolic acidosis. In some cases, individuals with bowel obstruction symptoms may be involved in body packing, a dangerous practice. While less frequent, cocaine use can lead to the infarction of the spleen or kidney. Cocaine users might experience minor abnormalities in liver enzymes, which are usually not symptomatic. However, in extreme cases, severe hepatic failure can occur, especially following hyperthermia caused by psychomotor agitation. The treatment of cocaine toxicity begins with airway management. It's important to note that succinylcholine is relatively contraindicated in rapid-sequence intubation. Instead, consider using rocuronium at a dose of 1 mg per kilogram intravenously, or another non-depolarizing agent as an alternative. Moving on to psychomotor agitation, the administration of benzodiazepines, such as diazepam at a dosage of 5 to 10 mg intravenously every 3 to 5 minutes, is recommended until the agitation is controlled. In cases of severe or symptomatic hypertension, diazepam at 5 mg or lorazepam at 1 mg intravenously should be administered, and this may be repeated every 5 minutes until the patient is sedated. For the initial treatment of hypertension, phentolamine is administered at an initial dose of 1 to 2.5 mg intravenously, and this should be titrated to effect. You may repeat the dose every 5 to 15 minutes, with a maximum dose of up to 15 mg. It is crucial to remember not to administer beta blockers, including labetalol, as beta blockade is contraindicated in acute cocaine toxicity. If cocaine-associated myocardial ischemia is suspected, an ECG should be obtained, although the accuracy with cocaine-associated chest pain is unclear. To manage agitation or hypertension, administer diazepam at 5 mg or lorazepam at 1 mg intravenously, and repeat as necessary. If aortic dissection is not suspected, aspirin can be administered orally at a dose of 325 mg. Nitroglycerin at 0.4 mg sublingually, with or without a continuous infusion, can also be considered. Phentolamine dosing is as mentioned previously, but it should be held for systolic blood pressure less than 100 mm of mercury. Lastly, if there is QRS widening on the ECG, which is rare and suggests profound toxicity, administer sodium bicarbonate at 1 to 2 milliequivalent per kilogram intravenously with a push. Again, remember, not to administer beta blockers in acute cocaine toxicity, as this is absolutely contraindicated. I'd like to talk about a medication that's quite common in our households, that is the paracetamol, also known as acetaminophen. This drug is a staple in many of our medicine cabinets, frequently reached for when we're dealing with pain or trying to reduce a fever. However, it's crucial to understand that acetaminophen poisoning is a significant cause of medication-related harm and, tragically, death. Most often, people are exposed to paracetamol through its proper use. Yet, it's also an ingredient in numerous cold and flu remedies, which, if not used judiciously, can lead to accidental overdoses. It's readily available and present in a variety of products, which unfortunately leads to a common underestimation of its potential danger. Research indicates that a considerable number of patients consume too much acetaminophen by misinterpreting the dosage instructions or not realizing that it's included in multiple medications they're taking concurrently. This is particularly prevalent among individuals with limited literacy or those who use acetaminophen frequently. Given these facts, it's not surprising that acetaminophen continues to be a leading cause of overdose and the liver failure associated with it. It's imperative that we, as healthcare consumers, remain vigilant about the medications we use, understand their risks, and adhere strictly to the recommended dosages. Acetaminophen is a common analgesic that's available in two forms: an immediate release, for quick pain relief, and an extended release, for sustained effect. When we talk about dosing, it's tailored to the individual. For children, we're looking at 10 to 15 milligrams per kilogram of body weight per dose, while adults typically require between 325 to 1,000 milligrams per dose. This is usually administered every 4 to 6 hours. But remember, there's a cap to how much you can take in a day: 80 milligrams per kilogram for children and 4 grams for adults. Now, let's touch on toxicity. It's a term that might sound alarming, but it's important to understand the thresholds. For children, toxicity is unlikely if the dose is under 150 milligrams per kilogram. For adults, the safe ceiling is somewhere between 7.5 to 10 grams. However, if a child takes more than 250 milligrams per kilogram, or an adult exceeds 12 grams in 24 hours, toxicity becomes a real concern. And in cases where the dose surpasses 350 milligrams per kilogram, severe liver toxicity is almost a certainty without proper treatment. Acetaminophen is swiftly and fully absorbed once it passes through the duodenum, which is the initial part of the intestine. Typically, serum concentrations hit their peak between 30 minutes to 2 hours after you've taken a therapeutic dose. But here's an interesting fact: the presence of food can actually slow down this absorption process. So, if you're taking immediate release acetaminophen, you can expect peak serum concentrations within 4 hours, unless, of course, you've also taken medications that slow gastric emptying, like opiates or anticholinergic agents, or if you've taken an overdose of extended-release formulations. In those cases, the peak could be delayed even further. Let's see the metabolism and pathophysiology of acetaminophen as it travels through our body. Picture this: you take a dose of acetaminophen, and it begins its voyage in the liver. Here, in the bustling hub of hepatic microsomes, a whopping 90% of the drug is transformed. Enzymes like sulfotransferase and UDP-glucuronidyltransferases spring into action, converting acetaminophen into sulfate and glucuronide conjugates. These transformed molecules are then ready to leave the body, exiting gracefully through the urine. But not all of acetaminophen takes this path. About 2% decides to be a rebel and exits unchanged. Meanwhile, the rest of it embarks on a more adventurous route. It undergoes a transformation by the liver cytochrome P450 enzymes, morphing into a substance called N-acetyl P-benzoquinoniamine, or NAPQ for short. Now, NAPQ is quite the character, reactive and potentially harmful. Under normal circumstances, our body is well prepared for this. A small amount of NAPQ is quickly neutralized by hepatic glutathione, turning into harmless compounds that are also excreted in the urine. However, when we take too much acetaminophen, the plot thickens. The usual metabolic pathways get overwhelmed, and more NAPQ is produced than our body can handle. If our liver's glutathione reserves drop by 70 to 80%, NAPQ starts damaging cellular proteins, leading to toxicity. In fact, markers of this toxicity can be detected in the blood as early as 1 hour after an overdose. So, what's the takeaway from this intricate process? It's a reminder of the delicate balance our bodies maintain and the importance of respecting the recommended doses of medications. The initial symptoms of acetaminophen poisoning are often subtle and do not necessarily indicate the severity of the poisoning. It's crucial for us, as clinicians, to recognize these early signs to prevent further harm. Let's discuss the progression of symptoms in stages. In the first stage, occurring within the first 24 hours post-overdose, patients may experience symptoms like nausea, vomiting, and general malaise. Interestingly, some may show no symptoms at all. Typically, lab results won't reveal much at this point. However, in cases of significant overdose, we might observe central nervous system depression and metabolic acidosis, though these are rare and often due to other substances ingested with the acetaminophen. As we move into the second stage, from 24 to 72 hours after the overdose, the real impact on the liver starts to become apparent. Initially, patients might seem to be getting better as the early symptoms subside, but this is when we need to be vigilant. Liver enzymes, such as aspartate aminotransferase and alanine aminotransferase, begin to rise, signaling hepatotoxicity. More than half of those affected will show elevated liver enzymes within the first day, and by 36 hours, this will be evident in all patients with hepatic injury. During this stage, patients may also experience pain in the upper right quadrant of the abdomen, where the liver is located, along with swelling and tenderness. We may also start to see signs of kidney involvement and, in some cases, acute pancreatitis. It's important to note that alcohol consumption can exacerbate these effects. Between 72 to 96 hours post-ingestion, we observe a peak in liver function abnormalities. This stage, known as stage 3, is characterized by a resurgence of initial systemic symptoms, now accompanied by jaundice and confusion, indicative of hepatic encephalopathy. A significant increase in hepatic enzymes, hyperammonemia, and bleeding diathesis are also present. Severe hepatotoxicity is evident when plasmalt and AST levels soar above 10,000, coupled with prolonged prothrombin or INR, hypoglycemia, lactic acidosis, and a total bilirubin concentration exceeding 4.0 mg per deciliter or 68 micromole per liter. It's also at this juncture that acute renal failure emerges in 10 to 25% of patients experiencing significant hepatotoxicity, and in over half of those with outright hepatic failure. Unfortunately, it is during this stage that death is most prevalent, typically due to multi-organ system failure. Transitioning to stage 4, which spans from 4 days to 2 weeks, we witness a phase of recovery for those who have survived stage 3. The recovery process usually initiates around the 4th day and is generally complete within a week following an overdose. However, in cases involving severely ill patients, this recovery may be protracted, with symptoms and laboratory values taking several weeks to normalize. Histologically, we see variations ranging from cytolysis to central lobular necrosis. The central lobular region, or Zone 3, is particularly affected due to its high concentration of CYP2E1, leading to the maximal production of NPK. Although histologic recovery may lag behind clinical improvement, taking up to 3 months, when recovery does occur, it is comprehensive. Importantly, chronic hepatic dysfunction does not follow as a consequence of acetaminophen poisoning. Now let's look at the steps in managing acetaminophen poisoning. Our primary focus is to ensure the patient's airway, breathing, and circulation are secure. This is paramount and should be addressed immediately upon presentation. Now, if an adult patient arrives within 4 hours of ingesting acetaminophen, we have to administer 50 grams of activated charcoal, unless there are specific contraindications. This treatment can also be beneficial for patients who have ingested extended-release formulations of acetaminophen, even if they present after 4 hours. For our pediatric patients, the dosage of activated charcoal is weight-based, at 1 gram per kilogram, with the cap at 50 grams. It's crucial to tailor the treatment to the patient's size and needs. Moving on to acetylcysteine treatment, which is our antidote for acetaminophen toxicity. We consider this treatment if the patient's serum acetaminophen concentration, drawn between 4 to 24 hours after ingestion, is above the treatment line on the revised Rumax-Matthew nomogram. TIS nomogram is a vital tool that guides us in determining the risk of hepatotoxicity and the need for treatment. In situations where we cannot obtain a serum acetaminophen concentration or it won't be available within 8 hours of ingestion, and we suspect an ingestion of more than 150 mg per kilogram, or a total dose of 7.5 grams regardless of the patient's weight, we proceed with acetylcysteine treatment. Furthermore, if there's a reliable history of repeated supratherapeutic ingestion, which means multiple doses over a period longer than 24 hours, and the serum acetaminophen concentration is equal to or greater than 20 micrograms per milliliter, or there's an elevation in AST and ALT levels above the patient's baseline, we should treat with acetylcysteine. In cases where the history is unreliable, such as when the time of ingestion is unknown, and the serum acetaminophen concentration exceeds 10 micrograms per milliliter, or there's an elevation in liver enzyme levels, treatment with acetylcysteine is warranted. If there's any evidence of liver injury and a history of acetaminophen ingestion, regardless of the serum concentration, again, we should not hesitate to treat with acetylcysteine. An oral dosing is suitable for non-pregnant individuals who show no signs of liver failure. The initial step in treatment involves a loading dose of 140 mg per kilogram of body weight, not exceeding 15 grams. This is followed by a maintenance dose of 70 mg per kilogram, capped at 7.5 grams, administered every 4 hours. It's important to continue this regimen until the criteria for cessation are met. Now, if a patient experiences vomiting within an hour of taking an acetylcysteine, it's imperative to administer a full dose again as quickly as possible to ensure efficacy. Moving on to intravenous dosing, there are various protocols available. Regardless of the chosen method, the goal is to deliver a minimum of 300 mg per kilogram of acetylcysteine within the initial 20 to 24 hours of treatment. A widely accepted protocol starts with a 150 mg per kilogram loading dose, up to a maximum of 15 grams, infused over an hour. This is followed by a second stage of 50 mg per kilogram, with a maximum of 5 grams, infused over 4 hours, and a final stage of 100 mg per kilogram, up to 10 grams, infused over the remaining 16 hours. Treatment is then maintained with a continuous intravenous infusion at a rate of 6.25 mg per kilogram per hour until it's appropriate to stop. For patients weighing less than 40 kilograms, a reduced volume of diluent is recommended. The IV intravenous dosing is generally appropriate in all instances of acetaminophen toxicity, and it becomes the preferred method over oral dosing in several situations, when a patient cannot tolerate oral medication due to persistent vomiting. If there's a medical condition that prevents oral administration, such as a corrosive ingestion or gastrointestinal bleeding, in cases of liver failure, and for pregnant patients. To stop our treatment with acetylcysteine, we look for a combination of factors: an international normalized ratio below 2, normal or significantly reduced AST and ALT levels by 25 to 50% from their peak, a serum acetaminophen concentration below 10 micrograms per milliliter, and overall clinical wellness of the patient. Let's back to our case. In the case of the 17-year-old adolescent found unconscious, the physical examination findings of drooling of saliva, coarse crepitations in the lungs, and pinpoint pupils are highly suggestive of organophosphate poisoning. Therefore, based on the symptoms presented, option B, organophosphate, is the most likely cause of poisoning in this scenario. Treatment would involve immediate stabilization of the patient with airway clearing, supplemental oxygen, decontamination to prevent further absorption of the poison, administration of atropine to counteract the effects of excess acetylcholine, and pralidoxime to reactivate acetylcholinesterase if administered early before aging. Ladies and gentlemen, as we draw this session to a close, I sincerely hope that the discussion we've had today has not only been enlightening but also immensely enjoyable. Your engagement and curiosity are what make these conversations truly valuable. If you found the content of this video to be of merit, I would be grateful if you could express your appreciation by liking it. Your feedback is crucial, so please feel free to write to me in the comments section with your thoughts and insights. Sharing this video with others can extend the reach of the knowledge we've exchanged today, ensuring that many more can benefit from our discussion. Moreover, by subscribing to this channel, You will be promptly notified of any new content we upload, keeping you updated with the latest discussions and insights. I am eager to continue this journey of exploration with you, and I look forward to welcoming you to our next session. Until then, thank you for your time, your enthusiasm, and your willingness to learn and share. See you in the next discussion. Bye.
Bye.